Okay, so hey everyone. My name is Guri. I'm a final year medical student here at King's. I was kindly asked by Usman and the Palliative Care Society to come here and talk and contribute to today's discussion. Compared to the preeminent speakers we have today and all the scholars in this room, it's going to be a bit and it's be a bit more relaxed and less evidence-based, but I hope I can do it some justice. So, all right. So me and palliative care. So from about I was a healthcare assistant in a 𝐃𝐎𝐍𝐈𝐎 ward before I started medical school. One of the things I hated about my job was being placed on a bay where there were people who required end-of-life care. I mean, trying to think about why that might be, whether it was this deep-seated uneasiness with the enormity of death, trying to understand and even try and deal with that situation. The other part of it was this idea of thinking that what could I do? What could I actually say when I meet somebody who's got a terminal diagnosis, who is dying? My solution to these problems was to essentially run and hide whenever I could. So that's meant to be me running. Just imagine the turban and the beard. But that changed when, in the end of 2012, I did a separate module along with the core course where I came to the Cicely Saunders Institute and spent a considerable amount of time with the team, including different members of the team, to try and get an understanding of how palliative care works and deal with all the misconceptions I had and all the prejudices I had. So, and the end result of that was that I learnt enough and developed my understanding enough to not want to run anymore. Not only that, around the same time, I also had to plan my summer elective for the following year, and I learnt enough from that module. I was converted to the degree that I decided that that wasn't enough, that I wanted to learn more about palliative care. And as part of that, with the help of Professor Scott Murray up at Edinburgh, he gave me the groundwork to keep running and run all the way to Uganda in Africa, metaphorically speaking. I mean, I took a plane. While I was in Uganda, so my main aim, having never been in Africa before, was to learn more about palliative care in the developing world. And also having never travelled before, I probably should have thought it through a bit more. But last summer I did end up going to Uganda with the aim of learning more about how palliative care works in both the community and the hospital setting. So as part of that, a bit of my placement was based at Hospice Africa, Uganda. And this lovely lady here, I'm sure many of you will recognise, is Professor Anne Merriman, who laid the groundwork and for the foundation of Hospice Africa, Uganda, in Kampala and a few other places within the country. The other thing I wanted to, which I felt was really important as part of that, is thanks to Professor Merriman's work and all the others who helped her during the difficult period of trying to establish palliative care services in Uganda. She advocated for and eventually, because I think at the time the government, there was a lot of misperceptions about morphine. I mean, there still are all around the world, but she managed to convince the government or the people in charge in Uganda that morphine was a good idea. Morphine for control of pain to ease suffering was a good idea, and now the Hospice Africa Uganda actually produces all the oral morphine for the whole of Uganda. And I know it's hard for me to express or show just how important that liquid is, but but being in a wards and seeing somebody in excruciating pain and seeing what morphine, when prescribed correctly, can do is an amazing thing. And so this deserves a bit of recognition. There's some of the other things about how palliative care works in the community in and around Kampala. So during my time with the hospice, I went on home visits. They run daily clinics for people to come in, whether that be people who've been like referred from the hospital, or whether it be just from the community, or through the outreach programs which the organisation also run. They also have a major role in helping with education and advocating for palliative care, not only within Uganda but also in surrounding African countries, and invite people to complete courses and take that learning back to their own institutions to improve palliative care services wherever they may be. The second part of my placement, and probably the main part, which where I spent most of my time while I was in Uganda, was with the Makerere University Palliative Care Unit, which Prof Downing here knows an awful lot about, and I was lucky enough to meet her and the rest of the team while I was there. So just to tell you a bit about palliative care in the hospital setting at Mulago. So Mulago has, I think officially has like around 1,600 beds, if I'm not mistaken. It's a huge hospital. At any one point I think they probably have about 2,200 patients, something like that. And when a needs assessment was carried out by the palliative care team, they found that about 40 or over 40% of all patients at Mulago had unmet palliative care needs or required palliative care input. And I'm not very good at maths, but using those figures, you can probably guess that that's an awful lot of people. With the team at Mulago, so they have like a dual role in both as a clinical unit, which provides palliative care services within the hospital. So that includes a team of doctors, some palliative care specialist nurses, but that's not. Well, while I was there, that wasn't like that was only a small part of it. I mean, like, so they also have this amazing volunteers network, people who would come in and like, because if you think about the numbers of people I just described, like there's no way that a team of 3 doctors and maybe 4 nurses can provide palliative care services for that number of patients. And one of the ways in which that was improved was by having like a large dedicated team of volunteers who came in, received training, and did a lot of the work to help provide like the best palliative care we could. A second link to that was that they trained link nurses in several wards around the hospital, so to like provide like essentially a link between the palliative care team and each ward. So that was another effective way of making sure that that palliative care did have an influence, or could actually be there or be available. Somebody would know about palliative care in the various wards around what is a like massive place. The other role is in academia. So the unit also provides teaching for med students at Makerere University. Also, not only that, it provides teaching and training for pharmacists, for other nurses, and like I'll come to why that's very important shortly. And like Hospice Africa Uganda, they also provide education and training for people from other parts of Africa and other parts of Uganda. And just a very quick thing about them. So that idea of having so many patients who need a palliative care need, and not like logistically, how do you meet that? How can a small team of people cater for hundreds and hundreds of patients on a daily basis? It's not possible. So what we did is, as well as help design and distribute protocols that were available throughout the hospital, they also had like a system where you could triage, if you like, palliative care needs. And so whenever a referral was made to the team, they would sit down and discuss it to to try and prioritise who needed to be seen when, and so that to try and maximise how efficiently we could provide palliative care services within the hospital. So just a very quick case study, because I could talk about my elective for hours and hours, but I've got I think I've got just under 5 minutes left, and even that's pushing it. So my case study is a gentleman called Mr. 𝐶𝐬𝐍𝐻𝐒. So he's a 34-year-old gentleman who's a primary school teacher up country. Up country is pretty much anywhere other than Kampala. So he has this history of a mass on his mandible, which he had for about a year. He actually had it resected 3 times, on 3 separate occasions by the surgeons, but each time it came back. So this happened quite early on during my time at Malaga, where he was admitted due to a recurrence of the mass, but this time it was increasing in size and was interfering more heavily with his function. So much so that even a few days after we met him, we were increasingly concerned about the tumour or obstructing his airway. So some of the challenges faced by Mr. 𝐶𝐬𝐍𝐻𝐒. So one of the big, or I consider the big differences between how palliative care works here at KCH and at Malaga is that at Malaga, as a palliative care doctor, you were essentially like a general physician within the hospital. So like you quite often get referred patients who don't have a diagnosis, but who for whatever reason have been referred, whether it be because they're waiting for a referral to the Cancer Institute, or whether that be because the doctors they're looking after them think they may potentially have end-of-life needs, but they'll need to move on to another patient. So by the time we saw him, he was actually admitted to the wrong ward, I think. And I think at the time they had quite a strict system of where the consultant who needed to see him, he had to be in a certain ward to be seen. So that was a problem. The other problem was, so he'd had various samples taken, but none had come to a definitive diagnosis. So he still didn't actually know what was going on and what was causing the problem. Another thing, so an important point about morphine. So morphine is produced by Hospice Africa Uganda and then sent to a national medical store in 𝐿𝑒ntebbe, which is nearby. From the national medical store, it's distributed countrywide. So you would imagine, so 𝐿𝑒ntebbe and Malago is not very far from 𝐿𝑒ntebbe, but because of problems with mainly bureaucratic problems with paperwork, there would be times where Malago, that hospital with 2,200 patients, would be without morphine, despite it being in a medical store several miles down the road. And that's a problem faced by many patients in the hospital, and one of them, and Mr. 𝐶𝐬𝐍𝐻𝐒, also had that problem. The other one is to do with radiotherapy. So this is a bit ridiculous, but the radiotherapy machine at Malago, for the whole population, they have one radiotherapy machine, which I think is from the 1960s or so, which routinely breaks down. And not only does it serve Uganda, I think it serves all of Rwanda, parts of Kenya, the Congo, and Sudan. How many millions of people is that? Just try and get your head around that. Think about the availability of radiotherapy here, and what's the main national referral hospital in Uganda, what radiotherapy services they have there. So so that was a major problem. So if you wanted to think about whether, so this patient might benefit from radiotherapy, you have to first think about whether the machine's working or not, or whether there's any spaces available to use it, which is, I know, is quite sobering, I think. He also had a power cut during his surgery, which meant that the surgeons weren't sure whether they removed all of the tumour. So palliative care, so how were they involved? So several ways. So it was actually the MPCU's responsibility to chase these multiple histologies and to try and figure out what it actually was, because the surgeons weren't happy to operate again without that. And so with the impending risk of obstruction of his airway, that was quite a challenge to physically do the run work to get a diagnosis and to make sure that he received care rather than just be left on the ward and to essentially suffocate and die. So as well as that, so following the holistic model, so things which are like particularly important in Uganda, which is a strongly Christian country, like things like sharing prayer can be essential for patients' well-being while they're in hospital, and as part of the palliative care service we did that. We also, since he had this mass on his chin, he hadn't seen his son for I think several months, because he didn't want his son to see him like that, so he wasn't in any contact with him at all, and that was a major source of anxiety for him, a major source of his pain. And as part of that, with the help of the palliative care team and the volunteers, we helped write a letter and also supported his wife, who was there with him. And so that's Simon after his surgery, and I think he's since had radiotherapy. But so this long list, I have no intention of actually going through it all or anything like that. I think the idea is to just, and these are just some of my thoughts. I mean, I'm sure there's many other challenges, and I think I've already ran way over my allotted time, so I'm just going to pass through. But it's just an idea that there are many. One of the things which I was wondering if I was a bit harsh at the end when I think it's easy to accuse somebody of a lack of will without actually I mean, how do you actually know that? I mean, I was only there for 10 weeks. I mean, so what do I do with that? Do I just say like, oh, you don't care, and so that's why all these problems are happening? Or do I think more along the lines of people like Dr. Merriman, Dr. Moira Leng, who heads the unit there, all the people at Hospice Africa Uganda, and think more about education and what, through teaching people about palliative care, helping them understand why it's important, why it's necessary, can change and help overcome all those challenges, or many of the challenges that I mentioned. That's why I think education, especially when it comes to developing palliative care services in the developing world, is incredibly important. And for like, it's easy for like, imagine yourself eating in front of the television, and an advert comes up of a starving child, like from whatever charity, asking you to donate money. It's very easy to just change the channel and carry on eating. But for the people who put their time into working in the developing world and helping people develop services, striving to improve care, that's a big deal, and I tip my hat to them. But the other thing is vision with action. So this is based on a quote from Nelson Mandela. I think he said, vision without action is daydreaming, action without vision is passing the time, but with the vision with action can change the world. And people who are out there, and like Dr. Harding, who does research to help develop the evidence base to bring about change and to improve services, I think that's vision with action. So a hand for Dr. Harding later, and Prof. Downing. And this is just some of those people with who combine vision with action. That's Dr. Moira Leng. She's amazing. If any of you ever go to Kampala.